Welcome everyone. Thank you for joining us today and happy Stop Clean Your Hands Day Eve. My name is Jason Thompson, Communications Officer for the Canadian Patient Safety Institute. And before we get started, I'm just going to pass it over to my colleague Gina Peck for a quick welcome in French.
Thanks, Jason. Merci et bienvenue à nos participants francophones aujourd'hui. La présentation des diapositives et l'enregistrement de l'appel sera affiché sur le website Institut canadien pour la sécurité des patients après 7 à 10 jours à partir de cet appel. Si vous avez des questions pour le présentateur, veuillez utiliser le chat box ou le Q&A aujourd'hui. Si vous avez une question pour moi comme entraîneur technique, envoyez-moi un message dans le chat box ou envoyez-moi un courriel et je vais essayer de vous aider. Une fois encore, merci pour votre participation. Back to you, Jason.
Thank you, Gina. First things first, I want to offer a few thanks, first and foremost, to our partners, Accreditation Canada, Infection Prevention and Control Canada, Patients for Patient Safety Canada, the Public Health Agency of Canada, and our new partner this year, Public Health Ontario. Their support in this event is very much appreciated. I'd also like to give a quick thanks to our sponsor, Gojo Canada, for their support of Stop Clean Your Hands Day. Last but not least, thank you to a small team of individuals here at the Canadian Patient Safety Institute who've made this event and this webinar a success. Anne McLaurin, Tricia Swartz, Gina Peck, and Abizak Saraga. Thank you to all of you for your help. The theme for Stop Clean Your Hands Day this year, which is tomorrow, May 5th, is Ask Yourself. Our goal this year is to inspire everyone who hears this message to pay attention to their inner monologues and conversations that they have with themselves. Ask yourself what small change you can make today to better yourself and set a great example for those around you. One of the activities the Canadian Patient Safety Institute hosted for Stop Clean Your Hands Day this year was our online quiz, How Clean Are Your Hands? We had one quiz for providers and one quiz for patients. We gave everyone a list of positive hand hygiene behaviors and had users click off which ones they adhered to. You would then get an outcome to show you exactly how clean your hands are. The provider quiz has been taken over 1,000 times so far, and when you look at the numbers, I think the most surprising thing to me was that roughly 65% of providers indicated they were cleaning their hands at all 4 moments of hand hygiene. For the patient quiz, it was taken 781 times to date, and to me the thing that jumped out was that only 47% of patients say that they actually speak up if their healthcare provider has not cleaned their hands. This quiz is still online, so you can head to handhygiene.ca and take it again, or take it for the first time if you haven't yet. The Stop Clean Your Hands Day video competition made a return this year. We had 18 videos submitted. Each of them is online on our YouTube channel. All in all, the videos have been watched over 10,000 times, and that's more than 13,000 minutes. And I'm happy to announce the winners. The judges' pick this year was Covenant Health, so congratulations to them. The judging panel was comprised of representatives from the Canadian Patient Safety Institute, Accreditation Canada, Infection Prevention and Control Canada, and the Public Health Agency of Canada. The winner for the People's Choice Awards, which was determined by the most views on YouTube, was Winnipeg Health Sciences Centre. So congratulations to both of those two organizations. All right, a couple of housekeeping items before we get started. Number one, as we go through the presentations today, feel free to enter any questions or comments you have into the chat box or the Q&A, and we'll do our best to respond to all of them. We do have time set aside at the conclusion of the webinar to answer any questions that come up. The webinar is being recorded, and it, as well as the slide presentations today, will all be available online for you after the call. And please do stick around after the webinar to take our poll. Without further ado, I'd like to welcome today's presenters. We have Jignesh Padilla, Dr. Kim Kores, and Cecilia Bloxham. First up, however, is going to be Jignesh. Jignesh is the father of a 5-year-old boy, a husband, and a passionate patient safety advocate. He was born and raised in India and moved to Canada in 2005. He works for the Saskatchewan Cancer Agency and is a member of Patients Patients for Patient Safety Canada since 2013. He also serves as a member of his local Patient Safety Advisory Committee with Regina Capel Health Region, and his long-term dream is to work on a patient safety reporting kiosk where patients and visitors can report occurrences and near misses directly to their care team, thus creating a more robust partnership and improvement in the healthcare sector. Jignesh, the floor is yours.
Thanks, Jason. Good morning, everyone. Bonjour. It is my pleasure to share a few words at this important event. My sincere thanks to CPSI and Patients for Patient Safety Group for providing me with this wonderful opportunity to share a few thoughts. I'm sharing my story, and I'm hoping that what I say resonates and represents the voice of all other patients. For all parents, there are some days in their life that are crucial. One of those days for us was a day of my son's surgery. I still remember it just like yesterday. At that time, my son was only 12 months old. We learned that a surgery on his spine was unavoidable. We frantically read all we could about the surgery, complications, and what we needed to watch out for. There were many things that we knew we wouldn't be able to control. However, one thing we were positive about was making sure that we and my son's care team can do everything possible to prevent an infection to my son. The consequences of getting an infection were bad, and the risks were very high. We learned that a spinal cord infection could easily result in serious conditions affecting not just the surgical outcome, but also affect our child's development and future. We were fortunate that we had the best team my son could have asked for. Dr. Keith Aronik from Stolleroy Children's Hospital was the head of neurosurgery department. He was very approachable, and above all, he was a true hand hygiene champion. Since surgery, we continue to meet Dr. Aronik on several follow-ups. Not even once, and I repeat, not even once, we have seen him miss an opportunity to wash his hands. Be it an exam room, pre-surgery, post-surgery, recovery, or even routine follow-ups, he always have washed his hands before and after caring for my son, and we are really appreciative of that. So what went well for us? Well, there were many things we are very grateful for and went very well for us. For example, we were given a preoperative instructions, and the team was taking the time for doing a hand hygiene during every patient-provider encounters. Some of the opportunities for improvements that we noted were to further streamline the process through written procedures, outlining key messages. For example, we were asked verbally to use antimicrobial soap. And now you may feel like, what's the need to have a procedure for use of antimicrobial soap? Well, as a parent and as a caregiver, we felt that we had lots of questions, such as how much in advance we should use it, how many times we should use it, are there any areas that need special focus or more focus, should we wash his hair with it, et cetera, et cetera. So the list goes on and on. During our stay, we also felt that some providers were not always sanitizing their hands in front of us. Now that doesn't mean that they may not have just cleaned it, but as parents and caregivers to our child, we always felt that it would reassure us if we saw a staff member sanitize hands in front of us and before touching our child. There are some disturbing visuals on the next slide that show us what can go wrong when all of the opportunities for hand hygiene are not taken. As you can see from these visuals, these pictures are from friends of ours who had an adverse outcome of their child's surgery due to an infection. No parents want to go through the surgery in the first place. And some of these infections resulted in repeat visit to OR within weeks of the original surgery, and that's all unplanned. Talking to these friends and families, we feel like a variation in practice may have played a role, as one of the family mentioned that they never got an antimicrobial soap for preoperative bath. Opportunities are unlimited, and we really need your help. I would like to seek your help and support on these three things. First, patients and family members are very grateful to champions such as this group for helping and spreading the message and best practices. As a care provider, please continue to do this. Use all sort of communications and channels. Communicate your message many times through many channels and many voices. The second thing I want your help with is if you see an empty hand sanitizer or a broken equipment, give a shout out. Bring it to your organization's attention. Help in reducing the time it takes to address this issue. And the last thing is be the role model that you are and wash your hands in front of patients and families. As Jason just highlighted, speaking up, I'm sure this group does not probably need to know because they don't shy away from speaking up. There was a survey done by CBC through one of the stories on hand hygiene and infection control, where the visitors were asked this question: what would you do if your doctor did not wash their hands when they came into the exam room? And surprisingly, as you can see, only 35% of the respondents felt that they will speak up. It tells us that we need to do a lot more to make it easier for patients, families, and colleagues to engage each other in giving feedback on hand hygiene. Lastly, I would like to share what I feel is needed and sadly lacking: a transparent communication and reporting regarding hand hygiene rates in Canada. In my experience, I could not find a one-stop site that I know which gives patients information on hand hygiene rate on various provinces or hospitals in Canada. When I tried to compile these statistics, it took me hours, several hours, and still some of the data I could find was several years old. And I wonder why. As a famous management guru, Peter Drucker, once told, you can't manage what you don't measure. And it is my plea to the healthcare community that please do your best and make this measure transparent and available. I know that this group is most important and influential group to keep the momentum on this issue. You can make the difference. Thanks for listening and being passionate about this topic. I really appreciate it. Over to you, Jason.
Thank you very much, Jignesh. The patient perspective that you provide is so valuable, not only to hand hygiene, but to patient safety in general. And so your thoughts and comments here today are very much appreciated. Thank you very much. If you have any questions or comments for Jignesh, feel free to leave them in the chat box, and we'll be able to address them towards the end of the call. Next up, I'd like to welcome Dr. Kim Korais. She is the Director of Clinical Programming and Research in the Substance Use and Concurrent Disorders Program at the Royal Ottawa Mental Health Centre. She's also an Associate Professor at the University of Ottawa and a Clinical Investigator with the Institute of Mental Health Research and a Clinical Health Psychologist. She has expertise in health behavior change, including how behavior change theories can be used to guide and inform novel interventions and improve healthcare worker vaccination update and hand hygiene adherence. She is here today to speak to us about hand hygiene compliance and whether or not behavior change theories can help. Kim, over to you.
Hello? Hello?
Yeah, we can hear you, Kim.
Okay, great. Sorry, look, something just clicked off at the same time. Sorry about that as well. Anyway, it's a pleasure for being here today. Thank you for inviting me to be part of this, and it's always great to hear everybody so passionate about this very important topic, including getting the family and client perspective involved. I'm here, as Jason mentioned, to speak about the role of behavior change in improving hand hygiene compliance, and what do we know from work in this area that can help us. Let's go. So I have no disclosures. So just to give a bit of a background, I don't think we need to tell this group the importance of hand hygiene, and I also don't think we need to tell the group how adherence rates to hand hygiene are suboptimal. We lack data on what the barriers and motivators are amongst many facilities, including long-term care facilities, and I'm going to focus a bit on that today because that's where we've done a lot of work in this area. What we do know, however, is that hand hygiene is a complex. What we know is that we use for things like smoking and exercise, when we talk about how do we change those behaviors, we actually rely on psychological theories of behavior change to develop effective interventions to modify or change that behavior. Yet, in the hand hygiene world, when we're looking at improving adherence or compliance or changing that behavior, we actually often don't use what we know about behavior change to actually change hand hygiene behavior. We kind of get stuck in this knowledge and education trap. And by that I mean interventions to improve hand hygiene have largely relied to date on improving individuals' knowledge. So it's the whole idea if we tell people what to do and if people just know enough, then they're going to change. However, we would never say that about exercise, for example. I know that exercising 5 times a week is very good for my health. I rarely do this, even though I know that it's good for me, even though I know it's the right thing to do. The barriers to me doing that aren't because I don't know. In fact, we know that people often, it's not that people don't do what they, it's not often that people don't know what to do, it's that they often just don't do what they know. So knowledge alone doesn't actually translate into behavior change. It's actually very well known across the behavior change world and across the psychology world. And while knowledge is necessary, people need to know what to do, it's just not sufficient for people to make change. Yet, why do our interventions focus on this? And then the interesting thing is, when our interventions don't work for knowledge, what we often do is we just say it louder and we say it stronger in order to get the response we're looking for. And if people just listen to what they're saying, they change. So how do we move forward beyond this? How do we move forward from the knowledge and education trap to actually improving hand hygiene adherence? And is there a role for psychological frameworks of health behavior change as tools to help us move forward with interventions that would be helpful? So the objectives of the work that we've been doing, and I work very closely with a team at Public Health Ontario, so I do want to acknowledge our collaborators there, and I will be talking actually a fair bit about collaboration through that, so you'll see the importance of that as we go forward. A lot of our work looks at using psychological theories of behavior change to identify what those motivators and barriers are for hand hygiene adherence, and using that information to inform novel interventions. So if we know what to focus on with these theories, and if these theories can give us some constructs to focus on that we can measure, then how can we use that to actually develop a novel intervention? And I'm going to also focus on the importance of fostering multidisciplinary intersectorial collaborations between public health, psychology, behavior change, infection control, and how together the strength in that collaboration to do something new. So I'm going to focus a little bit now on building the novel collaboration and why that was actually so important in the work. With the concept of if you do the same thing with the same people all the time, you end up getting the same result. So we really need to do a new thing with different people at the table to get a different result and to do something novel. So this work actually started back over 2 years, almost 2 years ago, maybe a bit over 2 years ago now. And what we initially did is we brought people across the province, we're in Ontario, together from public health, infection control, and psychologists. We brought a group of 20 to 30 people together. We said, you know, we really have this wicked complex problem with hand hygiene adherence. Complex problems require complex solutions. So what can we as a group, how can we use our knowledge and our different expertise to tackle this problem? So as a group, we reviewed the current literature, and then we looked at identifying gaps and opportunities. And we identified a common agenda to foster this collaboration and move things forward. So part of what we needed to do is, even though once we had everyone at the table, you needed a project to get people going, to get that momentum moving. So we actually got together and conducted a systematic review to look at, okay, well, what do we know about behavior change theory and hand hygiene? We know it's probably not been used that much, but what do we know from the literature? Is this a promising way for us to move forward? So I'm going to take a step away from collaboration for a second, and we'll talk a bit about our objectives of our systematic review. So what we want to do is two things. We wanted to review the effectiveness of interventions based on psychological theories of behavior change to improve hand hygiene adherence amongst healthcare workers, of course. And then we also want to look at, okay, so one thing for interventions to be applied and have those work, but are there other studies that have looked at psychological theories of behavior change to predict hand hygiene adherence? And what do we know about that? So our team reviewed multiple databases and reference lists, and we looked at English language published peer-reviewed studies of primary data to look at whether or not psychological frameworks can improve and or predict hand hygiene adherence. And what did we find? Out of the over 900 studies that were reviewed, 7 actually met our eligibility criteria. And for the most part, what we found were that that psychological theories of behavior change are effective at both predicting hand hygiene adherence, and interventions based on them generally result in increased hand hygiene adherence. So these are, as you see on the slide, just a list of some of the studies, and you can see it's a bit of a mixed bag. So there are numerous psychological theories of behavior change, and we've, in these 7 studies reviewed, basically focused on, there are about 4 or 5 different theories that were applied that showed to be successful. So what we concluded is, okay, so there is a potential benefit of applying behavior change theory to hand hygiene. Obviously, as I showed you, there's a lot of heterogeneity in the frameworks discussed. So it's very difficult to draw huge conclusions from 1 or 2 studies that are based on, you know, 1 per each theory. There was a lot of methodological limitations of the studies, but one of the key ones is it was actually unclear how the frameworks were actually informing the interventions. So the interventions in these studies that we reviewed actually relied on multimodal programs. So yes, they picked up some of the constructs of the behavior change theories, but they also focused on education reminders. So it's actually quite difficult to figure out what was impacting what. So based on that, back to our collaboration, we're like, okay, well, how can we design an intervention if we don't know what we're targeting? We know it's promising based on the systematic review. We know this is a way that we should be going forward. We know behavior change theories have been shown to both predict and interventions based on them create change in other behaviors. So let's move forward and bridge that gap here in the hand hygiene world. So together, this group got back and collaborated on a grant proposal that would look at targets for intervention. So we would look at a variety of different behavior change constructs, cross-theoretical, not just focusing on 1 or 2 theories, to figure out what are some of the important constructs that we'd want to target, so that if we were intervening, we know that this is sort of would give us the best way to move forward. So we actually had applied for a grant, and now we've already completed phase 1 of our project, building on the information that I just showed you from our systematic review, and I'm going to show you some of the results now from that work we've done. So in this work, we assessed 100 healthcare workers at 10 long-term care facilities across a variety of different regions in Ontario, including both urban and rural, and they completed a survey which, as I said, looked at different behavior change constructs different areas of different parts of these theories. And our survey included both closed-ended questions. So we presented a list of motivators and barriers that participants rated on their agreement with each of those barriers and motivators based on constructs of behavior change. And then we provided some open-ended questions to also get a sense of something we may have missed in our quantitative or closed-ended questions. And then, of course, we looked at self-reported self and coworker hand hygiene compliance. Then what we did is so you can see we had both quantitative data from the Likert scales and then qualitative data, which would have been from those open-ended questions. So we actually conducted a content analysis on the qualitative data of those open-ended responses using a behavior change framework called the Theoretical Domains Framework, which looks at a variety of different constructs of behavior change across many different theories. So what this Theoretical Domains Framework does is it looks at constructs of a variety of theories and kind of boils them down into overlapping or unique constructs so that you don't have to look at, 30, 40 different theories, but basically it boils down to a manageable number of constructs. So we, from that content analysis, examined meeting units, which basically just is a discrete idea being expressed by the healthcare workers, and we coded those into motivators, barriers, and suggestions to improve hand hygiene adherence. And then we explored common themes amongst the Likert scale items, so that was the actual survey where people would rate their agreement, using factor analysis to actually look at what were some key themes from there. And then we compared the themes from both the content analysis or the qualitative data and the factor analysis from the quantitative data. So this is a look at our demographics. The majority were female. Over half were PSWs and almost 20% were RNs. The majority were working full-time. The majority provided direct care to residents. And there was a large range of years working in healthcare. And you'll see that people report pretty good hand hygiene rates, and we know all the issues with self-report of hand hygiene, and you can even see that whereas people rate themselves as more adherent than they rate their coworkers, and knowing, these may be the same coworkers who rate themselves higher. So that's an interesting phenomenon as well. So when we look at the results of our content analysis, you'll see that the dark blue line looks at motivators, the light blue line is barriers, and the green is suggestions. And you can see that some of the key motivators for hand hygiene amongst healthcare workers are both their beliefs about their consequences to self and others. So what happens if one doesn't wash their hands? Protecting themselves and protecting others, often patients. Key barrier was resources, which included not only time, pressure, or workload, but actually supplies, which, as you heard for our first presenter, that real call to make sure we have adequate equipment and supplies and full ABHR machines. And another barrier was actually attention, memory, cues, so basically things like forgetfulness, competing demands for attention. And if you look at suggestions, the suggestions for how we could improve hand hygiene were often related to time, pressure, workload, supplies, and managing these competing demands. Interestingly, knowledge was not a significant motivator, barrier, or suggestion for how we can improve hand hygiene. And why that's so interesting is because that's often where we target our interventions, is around knowledge, and that doesn't look like it's actually one of our key motivators, barriers, or suggestions. Then, as I mentioned, so that was the results of the content analysis for those open-ended qualitative data. Then, remember, I talked about we did a factor analysis for the closed-ended questions, and we identified 3 key themes for hand hygiene adherence. The first was the beliefs about consequences to self and others, so very consistent with what we found in qualitative. Resources, just like what we found in qualitative, and the social professional role and identity. So really, they were very concordant results. However, the qualitative findings highlighted the important suggestion related to environmental resources, which we missed in our questions, so it didn't come out. Again, when you have these kind of Likert scale questions, you only get answers to the questions that you ask. And if you don't ask the question, you don't get the answer, which is why we wanted to look at both open-ended and closed-ended questions. And since then, we've actually revised this behavior-based tool to assess hand hygiene to include the stuff that we missed from the original items that we had in there. So if we take this together, I think we can see how psychological theories of behavior change do provide a useful framework for understanding motivators and barriers. And I come back to the importance of or maybe our misfocus on knowledge and training. That really wasn't a major barrier identified either by healthcare workers' own self-report or their open-ended questions, reaffirming the need to explore other interventions to improve hand hygiene. You may say, okay, we only did this with 100 people. Well, we've replicated this study actually with hundreds more people on the new tool we developed, and we consistently found in that new project as well that knowledge and training was still not a major major barrier or motivator that we identified. So really, we need to look at something different. Also think this work speaks to the importance of collaborating between psychology with those experts in behavior change, public health, infection prevention and control, and that's a really feasible approach. You have different people from different sectors around a table, and you find new ways of managing complex public health problems. So obviously these data are based on self-report, so maybe participants don't always recognize or express, or maybe there's that social desirability bias, so they don't say what they're really thinking for their motivators and barriers because they're mitigated by what other people may think of their responses, even though this was anonymous and even though nobody was there watching them. However, we recognize that, so one of our next steps that we've actually just completed work on was looking at people's implicit as opposed to explicit attitudes towards motivators and barriers. So what people, as opposed to just what they express, how they implicitly view these motivators and barriers, and we just finished a project looking at that as well. So where next? So I think it's safe to say that in the area of infection prevention and control, we're really in the infancy of applying psychological frameworks. We have other work, and it's not the purpose of this conference meeting today, of course, where we've also applied this to vaccine as well, to also show how we can even predict vaccine behavior using these psychological frameworks of behavior change. As you can see from the systematic review, many theories remain untapped in the area of hand hygiene. And what we're continuing to do is identify those promising constructs that we need, not just focusing on one or two theories, but cross-cutting and looking at both explicit and implicit ways and more habitual ways as well. If you look at vaccination is something you may do, once a year if we look at the influenza vaccination. However, hand hygiene is something people are expected to do hundreds potentially. If I work in a healthcare setting, how many times I wash my hands a day? Times a day, if not more. So that really is more of a habitual behavior. So our work has now started looking at what is the role of habit and in hand hygiene, and how can you create a behavior as a habit to promote hand hygiene adherence. So from the work that we've done in both studies I presented today, we've identified some of those key targets, so now we can look at developing an intervention study in collaboration with our partners in long-term care to improve hand hygiene adherence. So the question I think we're left with from the healthcare setting world, the public health world, from those of us in infection prevention and control is, are we ready, willing, and able to change how we deliver our interventions to improve hand hygiene? Are we ready to do something in a different way? Thank you.
Thank you very much, Kim. We do have several questions that came in through the chat box, so keep them coming, everyone. We will definitely have some time towards the end of the call to revisit some of those with Kim and our other speakers. Our final presenter today is Cecilia Bloxham. Cecilia is accredited in communications by both the Canadian Public Relations Society and the International Association of Business Communicators. As the Senior Director of Strategic Communications for CPSI, Cecilia is dedicated to the mission of safe healthcare for all Canadians. She has worked in healthcare communications for 10 years and joined CPSI from a senior role in public affairs at Capital Health in Edmonton. She'll be speaking to us today about engaging behavior change. Over to you, Cecilia.
Thank you very much, Jason. Are you able to hear me?
We can, yes. Please proceed.
Perfect. So I'm going to speak to you a little bit about engaging behavior change through marketing and communication tactics. What does it mean to be engaged? When you're engaged in something, you feel a profound connection to it and you feel a passion towards it. When you're engaged, you feel accountable and a sense of ownership. When you're engaged, you have a well-defined role of what is being asked of you with a clear call to action. How do you change behavior through communications and marketing? People will change their behavior if they see the new behavior as easy, rewarding, and normal. It has to be easy. People need to feel that they have the skills and knowledge to change and there are no obstacles in their way. It also has to be rewarding. The need and understanding that doing this behavior will give the results that are valuable. Another piece is normal. People need to feel like this change in behavior is the norm. Role models or behavior change that people are modeling can also impact this. So in order to engage people and change their behavior, I'm going to share with you a campaign that the Canadian Patient Safety Institute used across Canada during Canadian Patient Safety Week. We were able to evoke passion and create a sense of ownership by making this campaign easy, rewarding, and normal. We also did this by addressing these 5 key points. We wanted to reach the right audience, we wanted to give incentive, we wanted to be memorable, we wanted to make it easy, and we wanted to create a positive feedback loop. We know that in order to ensure your message reaches the right people, it needs to be the right product, the right person, at the right time. You need to aim high. It's all about balance. If you try to reach everyone, you'll likely appeal to no one. And if only a handful of people meet your criteria, you've gone too far in defining your target audience. So with this campaign for Canadian Patient Safety Week, we distilled our work into 3 distinct target audiences. We wanted to define who are the key influencers or the leaders, who are the providers and what does this mean for point of care on the front line, and of course, what's in it for me as the patient or the public. We also wanted to give incentive. When you give incentive, it provides motivation and an encouragement to act. So for our campaign, the theme was Questions Save Lives. We were asking providers, patients, family members, and leaders across the country, what question would they ask in order to save a life or provide safe care? And the incentive that we gave was ensuring that we retweeted and celebrated every act of engagement that you had. For the health ministers, this was huge credibility as leaders or key influencers being recognized across the country. And here we have the Minister of PEI and the Minister of New Brunswick. For healthcare providers, we wanted to celebrate their passion and commitment on the front line to ensuring that they were asking the right questions to save lives. And here we have EMS, and we also have a physician. And for the patient, we wanted to provide the incentive that they were knowing that they were engaged in asking the right question. And here we have 2 patients that submitted their questions. The other big piece for a communication and marketing campaign is you need it to be memorable. You need to use the halo effect. You need to find an unforgettable people that have huge amounts of respect and profile them. So in this particular case, our key influencers were Dr. Verna Yu from Alberta Health Services, Dr. John Maxted, Christina Kraus from the BC Patient Safety Quality Council, and Ray Rosette, the CEO of Canadian Health Leaders. Making it easy can be a challenge. You have to make it easy, you have to make it easy to understand, and you have to make it easy to act. I think we succeeded in this when you can see the results. We received hundreds of questions from across the country of what patients, providers, and leaders would ask in order to ensure safe care. And finally, you need a positive feedback loop. For this particular campaign, we used gamification. We know that gamification is having a huge impact in healthcare, and we developed a quiz. Are you a patient's dream or scream? What kind of provider are you? Are you a provider's dream or scream? What kind of patient are you? We had a huge level of engagement with this positive feedback loop because as patients and providers took the quiz, they were actually ranked as to what type of provider and patient they were. I will emphasize that this is a cheeky quiz, and that was intentional because we wanted to make it fun and something that could be easily shared on social. And that brings us to Stop Clean Your Hands Day. So as you can see, we were really specific with our target audience. We created an incentive with the video competition that we'd profile you across the country. We made it memorable in the sense that there is such incredible talent in this country for creativity, and the videos that we received were phenomenal. We wanted to make it easy to be a part of it, and then with the positive feedback loop as well, ensuring that you had an opportunity for comments. And tomorrow, we're very excited to be profiling Minister Philpott cleaning her hands at the Children's Health Hospital of Eastern Ontario. And finally, I think with any marketing and communication campaign, you have to bring heart. Heart is involved in everything that we do in healthcare, and I think this really is what drives the passion for engaging behavior change. Thank you very much, Jason.
Thank you, Cecilia. All right, we've got plenty of time left for some questions. I know that some have come in through the chat box, so I'll have Gina unmute each one of our panelists, and some will be directed at you. Others, if you just want to jump in and offer some of your thoughts, please feel free to do so. One of the questions that came in, or rather a suggestion, was why don't we create a handout that emphasizes why don't I clean my hands when I know that I should? I'm curious to find out, and perhaps, Kim, you would have some insights here. How do you think this approach would be received by healthcare providers, and do you think that it would work?
So the question is, why don't I clean my hands? Sorry, I try to find the Q&A, but the box is small, so I can't read it. So just repeat what you said. So a handout related to why don't I clean my hands when I know I should?
Yeah, so almost maybe emphasizing, you know, some of the more negative behaviors around hand hygiene as opposed to emphasizing the positive.
I think we'd want to be a bit careful with that. So when we think about even our messaging, it's actually more helpful to have messaging that 80% of people clean their hands as opposed to 20% of people don't clean their hands. Because if you look at the 80% and you're someone who doesn't clean your hands, you may think, oh, well, I'm a bit in the minority. If you flip it the other way and look at the 20%, you may say, oh, I guess I'm, you know, there's lots of people like me. And I think that's a bit of the point that Cecilia was just talking about. I think I got her name right. Cecilia was just talking about in terms of, you know, social role identity and role modeling and who we identify with. So I'm not sure if we'd want to have a campaign around all the reasons why people don't wash their hands. Although balanced views are important, I think a whole campaign on that may not have the results that we want. I'm interested in what other people think, though. Cecilia, maybe from your work, or Jignesh?
It's Cecilia. I'll jump in here. One piece that we really strive for at the Canadian Patient Safety Institute is we try and keep it on the positive. And we find that even in our engagement with Patients for Patient Safety Canada and all of the stories that we share of patients that have experienced harm themselves or have lost a loved one due to harm in healthcare, we only profile these individuals and their stories when we're able to end it on a message of hope. And we find that no one goes to work in order to cause harm, and we really want to keep the tone on the positive level. So we find that when you keep it positive, it impacts more change and creates that passion and creativity that you need.
Yeah, and to add to that, Cecilia, it's Kim again. We also don't want to shame and blame. So the idea of why you should be doing something or why aren't you doing what you should, that often shuts conversations down and people actually stop listening when there's a feeling of shame and blame involved in that.
I would agree with both of your comments, Kim and Cecilia. One thing which is not answering the question directly, but what as a best practice example which I've seen was home care community nurse. She was sharing what their group did to decrease the non-compliance and increase the hand hygiene compliance. What they did was they encouraged all of their staff and basically invited them to bring pictures of their families, kids, parents, etc. And then they used those pictures and created the hand hygiene messages and used that near the sink, any opportunities or hand sanitizer, etc. So every time these care providers were trying to pass by, it reminded them, the infection they may have by not washing their hands or the germs, they could easily bring it to their loved ones as well. So it was a kind of a dual motivator. And I think from what I heard from that care provider, that it worked very well and it increased their compliance.
There's a comment that just came in through the chat box saying that the Royal Alex in Edmonton has a very successful campaign called No Excuses, and it's a graphic of a hand with words on it. And the words are all the different common excuses that people could provide around hand hygiene, and that staff get a pin when they pledge to clean their hands and ask others to clean their hands. We've also got a question around whether anyone has heard of the always event, perhaps as opposed to a never event. Has anyone heard of an always event concept being used around hand hygiene?
Can we comment on the last one or no? Sorry.
Absolutely. Yeah.
Okay. This is Kim here, and it's great that the Royal Alex at Edmonton has found something that works. I think one of the cool things about doing these kinds of cross-national talks is that you have people sharing their experiences, their successes, and frankly maybe challenges too, and we can all learn from each other. So I wanted to comment on that for those people who are sharing. But in their intervention, it looks like they actually have 2 or 3 interventions in one. One was, commenting maybe a bit about why people aren't washing their hands. But the other is actually positive reinforcement and a contingency management strategy where staff actually are getting a pin when they pledge to clean their hands and then asking others. So there's actually several interventions in one, and the last 2 really are behavior change type interventions with focusing on rewarding people and for both managing their behavior and for encouraging others. So I just wanted to comment on that.
Inger, your comment around the No Excuses campaign at the Royal Alex has a couple people asking some questions around where they can find some more information. So after the call, we'll effort to perhaps connect the 2 of you, and that information can be shared. We got several questions or comments around speaking up to a healthcare provider when they're seen to not be washing their hands, and around the fact that we do perhaps have an adversarial healthcare system, and that a lot of times as a patient, you don't want to incur the wrath of your provider. You don't want to make yourself to become a target. Are there any thoughts from any of our panelists around kind of the status of that, or is that something that you think we can eventually get over? What's it going to take?
It's Cecilia. I'll comment personally on this one. I think having been at the Canadian Patient Safety Institute for 9 years and working on Stop Clean Your Hands Day since 2006, I can personally say that when I go for my annual checkup, I struggle to ask my provider to clean her hands before the appointment. So it's challenging. It takes courage, but as we say at the Canadian Patient Safety Institute, ask, listen, talk, and you really should feel able to do that, but it certainly is. It's a vulnerable position to be in.
Before I comment, Jignesh, as a family member, I don't want to take away your voice because you had touched on this. I don't know if you want to comment. Sorry, it's hard to see your fellow panelists because, well, we're in different areas of the country.
Yeah, no, thank you for the opportunity. I feel like there is still a lot more work to be done. There are definitely pockets of excellence. And again, Stollery's Children's Hospital and Neurosurgery Department is one example where a head of the department has really taken over the role as a champion, and he's visible, he's active, he's out there. And I remember, like, when we were concerned, we kind of had that conversation with him, and he brought me a bottle of hand hygiene and put it in front of my son's bed and said, hey, you go ahead and tell everybody if you want them to still wash their hands in front of you. And that was very encouraging. And at the same token, I have seen during my son's care that there were occasions where we literally had to stop somebody, or where, you know, repeatedly they were not complying, right? So there are pockets, and I'm very hopeful that we're turning the needle on this towards the excellence.
And just in terms of behavior change, the same way we wouldn't rely on other people to mitigate or moderate or be responsible for my exercising or my quitting smoking, I think that would kind of apply to hand hygiene as well. Who's the onus on to make change, and is the onus for patients to change healthcare workers? So, and yes, I think it's obviously, you know, we need patients to ask and speak up. I don't think we should take away patients' and families' voices at all. But I think if we're looking at affecting sustainable change, I wonder if that's sort of the best way moving forward. Although I do know that there's research that may support that. I just question its feasibility and how much patients can always watch healthcare workers.
Okay, great discussion. I know on this topic, I'll offer an anecdote, if I may. When my wife was pregnant and we were having a lot of different doctors' visits and appointments, I made a point, and, you know, working at CPSI, I was aware, but I made a point of thanking the providers. I still felt uncomfortable asking them to clean their hands if I noticed they hadn't or I didn't see it, but for those that I did, I made a point of thanking them, and the reaction that I got more often than not was one of surprise, and people weren't used to that. And so, you know, from my standpoint, I was just trying to maybe reinforce some of that positive behavior. You know, if it's an adversarial system, perhaps you can catch more flies with honey than with vinegar, I think is the old expression. Question here for Kim. What are the next steps of your study? How are they going to grow their gains and spread what they have accomplished?
So what we've just done now is, okay, so in terms of how we're going to spread what we've accomplished, so there's two questions. What is the next phase, and how are we going to spread what we've known, so the knowledge translation? So, so this kind of work is out there both in, well, one piece of work has already been published actually related to this, and I can't see any slides right now. There's something wrong with this, but I believe I had the citation in the presentation where our systematic review was published. Also, the next phase of our study is in the works of being published right now and is also being presented at national and international meetings. So that's how we're getting the word out there about that, and of course events like this. In terms of next phases, what we're doing is we're looking at, we just finished our data collection on our implicit attitude. So we actually used something called an implicit attitude test, which I'm not going to get into, but it's a way of getting at people's underlying beliefs and attitudes that they wouldn't necessarily report. So we just did that at, again, many long-term care facilities with healthcare workers around Ontario, and that data has been analyzed, and we're actually able to show that not everything people say is always what we think. So that data is in the process of us putting it together, and our next step is taking all our information that we have from the implicit work that we did, as well as the tools that we've created, and starting to mock up an intervention, and we're actually applying for a CIHR grant for that. That's our next step.
Excellent, that's great. I think that covers it for the questions that have come in so far. So I'd like to offer my thanks and appreciation to every one of our panelists today. I think this was very informative, and I hope that all the participants on the line got a lot out of it. Just a reminder that this call is being recorded. It will be posted to our website as quickly as we can, along with all the slides, so all that information will be there at your disposal. Tomorrow, May 5th, is Stop Clean Your Hands Day, so be sure to celebrate it in your local sites, and let's raise some awareness around hand hygiene. Before I sign off, I'd just like to offer a reminder that we will be putting a poll up, and your feedback is very valuable to us. So please take a few minutes to let us know what you thought about today's webinar. With that, we'll sign off. Enjoy the rest of your days, and we'll talk to you soon. Bye.